First new class of pain drug in 25 years. That's the headline everyone saw in early 2025. Dr. Z, that sounds enormous. Is it actually enormous or is it marketing?
Great question, and I want to do this one like closing arguments in a courtroom. I'll take the case for the hype, the genuinely exciting story. You cross-examine me with the trial data that complicates it, and we land the jury somewhere honest in the middle. Deal?
Deal. You're up first. Make the case.
So the drug is Suzetrigine, brand name Journavx from Vertex. The FDA approved it January 30th, 2025 for moderate to severe acute pain in adults. And here's what makes it a landmark. It's the first genuinely new pharmacologic class of pain medicine since the COX-2 inhibitors back in 1998. Mechanistically, it's elegant. It selectively blocks a sodium channel called NaV 1.8, which sits on the peripheral pain nerves, the nociceptors. It does not cross into the central nervous system.
And that's the part that matters for the opioid crisis.
Exactly. Because it never reaches the brain's reward circuitry. There's no euphoria, no sedation, no dependent signal. It is not a controlled substance. You can hand someone real analgesia for acute pain with zero addiction liability. And the pivotal phase 3 trials, after abdominoplasty and after bunionectomy, both beat placebo convincingly on the primary pain endpoint. The treatment effects were large and statistically significant. So, new mechanism, no addiction risk, real FDA approval, beat placebo. That's my case.
Okay. Permission to cross-examine.
Granted.
You said it beat placebo. True. But beating placebo isn't the bar that matters at the bedside. The trials had a second, arguably more important comparison, head-to-head against hydrocodone-acetaminophen, a standard generic opioid combination. And on that comparison, in both trials, Suzetrigine failed to show superiority.
It did.
And in the bunionectomy trial, it wasn't even a tie. The numbers numerically favored the old opioid combo. So the honest statement is, this brand new, expensive drug is not more effective at relieving pain than a cheap generic we've had for decades.
That's a fair and important correction. So counsel, if it's not more effective, what's the actual value proposition?
Tolerability. And this is where it earns its place. In both trials, Suzetrigine caused significantly less nausea and vomiting than the opioid combination. Plus no addiction potential, no respiratory depression, no constipation the way opioids give you. So the pitch isn't better pain relief. The pitch is comparable pain relief with
which for the right patient is genuinely valuable. Someone with a history of substance use disorder, someone you're desperate to keep opioid free, someone who can't tolerate opioid nausea.
Agreed. But I've got one more line of cross-examination, and it's the one that worries me most. Chronic pain.
Go ahead, because this is where the marketing gets ahead of the science.
The acute pain approval is solid. But people immediately want to use this for chronic pain, sciatica, diabetic neuropathy. And the chronic pain data are weak. In the lumbosacral radiculopathy trial, sciatica, Suzetrigine technically met its endpoint, but only because it improved from baseline. When you actually look at drug versus placebo, the curves essentially overlap. It did not separate from placebo. Vertex has since paused and redesigned that program.
In the diabetic neuropathy trial?
Even shakier, it had no placebo arm at all. So you literally cannot make an efficacy claim from it. Patients improved, sure, but people improve on placebo in pain trials constantly. Without a control, that number means very little.
So to be crystal clear for anyone prescribing, the approved, evidence-backed use is short-term acute pain. Chronic pain is not an approved indication, and the data there do not currently support it.
What about practical prescribing pearls before we close?
A few. It's metabolized by a liver enzyme pathway, so you avoid it with strong inhibitors of that pathway, and that includes grapefruit juice and grapefruit, which patients never think to mention. Avoid it in severe liver or kidney impairment. The common side effects are mild: itching, muscle spasms, a bump in a muscle enzyme called CPK, and rash. Dosing is a loading dose, then twice daily.
So, closing statements. Where does the jury land?
I'll land it as balanced enthusiasm. This is a real scientific achievement, the first truly new pain mechanism in a generation, and a non-opioid option we did not have before. That matters, but it is not a magic bullet. It did not outperform a generic opioid on pain. Its real edge is tolerability and safety, and its chronic pain future is unproven.
So don't buy the hype and don't dismiss it either. Reach for it when avoiding an opioid is the goal and the pain is acute. Keep expectations realistic on the pain relief itself.
Perfectly put. A genuine new tool, used for the right patient, with clear eyes. That's the verdict. Thanks for listening.